I had the distinct advantage of being a fellow with Dr. Chapman at University of Washington and Dr. Skuyan here, and I'm so glad that those two forces combined to form a fantastic fellowship. So basically, I just wanted to run through a few objectives for this talk. To understand instrumentation, you really have to have a little bit of the grasp of the historical aspects of it. So I want to cover this very briefly. I want to go into the biomechanics of the instrumentation, which is namely the anchors and the longitudinal members that we commonly use, namely the screw and the rod in the thoracolumbar system. Talk a little bit about the mechanisms of how they can fail, and then look at some tips for success with respect to how we utilize implementation in order to achieve our goals, which is to establish a strong construct, whether it be for degenerative disease or deformity, whatever our goal is. So very briefly, I have half an hour, so I'm going to race through this. Deformity really was tackled from ancient times when it was understood, it was discovered that traction, distraction had a role in terms of actually straightening out. And you can see these kind of medieval appliances utilized on patients to literally and physically achieve that. By about the 19th century, it looks like a torture method here, but Louis Sayre published a textbook on the use of suspension, which in fact is distraction, and then maintaining that suspension with plaster of Paris. And that had its kind of origins in the 19th century, but sequential casting has been very successfully used even up until today, where it's used for early onset scoliosis. It still has a role in early onset scoliosis, particularly with very young children, either to correct the deformity completely or to delay surgical treatment as a result. And I'll never forget the days of helping to apply the Risser cast as instructed by Dr. Chapman, and initially being dubious, but seeing its benefits. So then, as a historical kind of aspect progressed, we progressed on to understanding that fusion or arthrodesis had an important role in terms of achieving stability by eliminating motion with respect to these segments. And this was understood as early as the 1900s, and together with that came these various kind of discoveries which were absolutely astounding with respect to pushing the science forward. So we'll talk about Harrington in a minute, but Marshall Urist in 1963 identified bone morphogenic protein. And in fact, his student, I believe, an associate, worked with him to receive a Nobel Prize based on this discovery. But it was he who understood and discovered this innate native protein that has such an integral role with helping to achieve arthrodesis. And Paul Harrington, another historical highlight figure from the 1960s, was the first to utilize intraoperative distraction system in the form of this Harrington rod and hook. He would place it. Its main benefit was to correct the coronal aspect of the curve, and in doing so through distraction, be able to reduce this coronal imbalance. And he used a large rod to do this. Often it, of course, only was corrected in the one plane, which is the coronal plane, and it resulted in loss of lordosis, segmental lordosis, and thoracic kyphosis. So it often would result in a flat back syndrome. But in reality, it was a major event in terms of spine instrumentation. What followed him were others such as Lukey, who then decided to apply segmental for a correction of the deformity by using wires to the rod and bringing the spine to the rod, and great success was achieved that way. When combined with this Galveston to achieve this kind of Lukey-Galveston uni rod, and it still amazes me how this was able to be achieved. They were able to obtain not only the correction that we talked about, but iliac fixation as well. And of course, you look at this and you kind of understand some of the failures that they would have as well, such as windshield wiping and loss of good fixation in the pelvis and so on. And then came Cottrell and Dubuisset, who came up with the CD instrumentation system, combination of hooks, crosslinks, but also significantly so fixed screws. And they were able to, again, have segmental purchase or segmental fixation in terms of being able to manipulate the rod or the spine and the rod together. It was cumbersome to some extent, the earlier parts to it. The screws needed to be placed straight ahead. Seating the rod was difficult. There was a lot of fixation, however, with these limited parts. And again, it was a quantum leap in terms of the available instrumentation. So Cottrell, Dubuisset, and I believe that Dr. Dubuisset has actually been a guest here of SSF. It's quite an honor. Yeah, there you go, for 4 years. So really, in the early 80s, they propelled this idea of global rod derotation, where they would set a rod at a off balance or sagittally to one side, set it in motion, and then through the use of in situ bending, of then rotating that rod globally, using wires, cross-linking with the wires as possible, addressed both the sagittal as well as the coronal planes. But of course, there were significant stresses on these instruments, particularly with the inability to really move the screw. And then, of course, Jürgen Harms and Schuffelbarger brought about the Moss-Miami system, where there was polyaxial ability added to the monoaxial screws, and you could drop the rod on top of these screws, or through these screws, sorry, decrease the fiddle factor. Offsets came into being. There was a hybrid offset evolution, washers, connectors. There were 1,000,001 different components to the instrumentations, which made them cumbersome to use, but very powerful. And then the polyaxial screw inline system came around, where the rod was able to be placed across the top of the tulip and set into place. And then Dr. Suk, who you've heard, was a real proponent of the thoracic pedicle screw. I don't think it was approved by the FDA here in the United States till much later, but he was utilizing this in Korea with great effect to do both global but also segmental direct vertebral rotation to correct these the apices of these curves and the rotatory component of these. So that's a little bit of the history. There's a lot of gaps there, obviously, but I just wanted to bring up some of the highlights there. In addition to that was an evolution of understanding classification of these curves and understanding the classification of these deformities. And this goes all the way back to John Cobb in 1948, who understood that you could basically systematize the angle of the deformity, particularly in the coronal plane. And that has evolved all the way to modern Lukey and Lukey-Uribe systems of classification. You'll meet Dr. Uribe shortly. But this was nothing new, the understanding of sagittal balance and so on. This came all the way from many, many years ago. And in fact, it was really surgeons that propelled the advances here in deformity correction, as opposed to any proprietary company or other groups. So the evolution of these techniques really came with the evolution of surgical understanding. So if you understand that, the next question that you have is, well, what is the purpose of the spine? What is it that we're actually utilizing this instrumentation for? This is obvious. The spine protects the neural elements first and foremost. It stabilizes the limbs. It supports the body weight. But it's also incredibly important as a member of the locomotion team for the skeleton. And in so doing, the instrumentation has to support that purpose as well. So when we then apply instrumentation either segmentally or globally in terms of stabilizing the spine. It's really trauma, deformity, infection, tumor, degenerative conditions that we're hoping to stabilize. And the principle is very simple. It is there, for the most part, to act as scaffold until biological fusion is achieved. And when it does that, when biological fusion is achieved, often the instrumentation itself acts purely as a scaffold. In many cases, it is redundant. In the pediatric population, it can be removed. But it is, again, this race between failure of the instrumentation and arthrodesis. Biological arthrodesis is achieved in order to achieve the objectives that you have, which is to stabilize and to eliminate motion segment in the spine for the purpose of correcting the purposes that we talk about the spine in these conditions. So what's the ideal instrument? Well, it's got to be strong enough. It has to be able to help you restore normal alignment. You have to be able to insert it easily. It can't back out. It can't fracture. You have to be able to correct multiple planes of deformity with it. But most importantly, with respect to what we said, it has to have minimal footprint to allow this generous area for bone graft to occur, for bony arthrodesis to occur. And of course, in our society today, it has to be cost effective. Otherwise, it's not useful. And your hospital system will not allow it. So let's talk about a little bit of the basic biomechanics here. And for the orthopedic surgeons, I apologize, you can go to sleep now. But for me as a neurosurgeon, this was eye-opening, the understanding of this, and it had not really been covered. So the concept of the screw rod system is much like that of a cantilever, where there is a longitudinal member, and that's the rod, and it connects anchors within these segments, which are typically the pedicle screws that we have. And this system, this cantilever system, can be of three different varieties, and we can go into the details, but very basically it can either be fixed, non-fixed, or have an applied moment force to it. In other words, it can take force in different vectors to achieve its goals. But the basis of it is that there is a load that is applied in the body sequentially down from the cervical, from the skull all the way down. This is an applied load. It increases at each descending level, and it's resisted by a resistive force or a shear force, which hopefully in neutrality by Newton's law of physics typically would cancel each other out. Now, at a certain fulcrum, the force that's applied and the distance from that fulcrum or the axis of rotation to the tip of that anchor is known as a moment. In the spine, it's known as a bending moment. So you have an instantaneous axis of rotation around which these forces are applied, and a certain force or moment is applied as a respect to the distance from that fulcrum onwards and the force itself. And this is important, as we'll discuss. So the screw acts as a load-bearing beam, essentially. Again, like I said, this load is applied to the head of the screw across this axis of rotation, and you have a fulcrum, and that motion around that fulcrum is known as a moment. So far, so good for the neurosurgeons, right? The magnitude of this moment varies in accordance to that force and the distance. I think so far we have this. This resisting moment is generated by this downward stress applied by the body of the screw behind that fulcrum. And so when it comes to short screws, then there's only a short moment able to be applied by that cantilever. But when you hook it up to multiple different segments, there's great strength by increasing the resistance to the applied force and increasing the moment. Why do I talk about this? I talk about it because it has practical and clinical applications. I've certainly heard Dr. Chapman talk about this. I'm sure you have understood this concept that deformity begets deformity. So, for example, when you apply that axial loading force, we talked about the fact that this moment is created around the fulcrum. The further you are, let's say that some kyphosis is built in and that distance is increased from that axis of rotation, Well, guess what? That increases the moment, as we know, because a greater force is applied, and the larger moment then begets a larger bending moment, which increases the kyphosis. So it's a vicious cycle that needs to be arrested by decreasing the distance of the axis of rotation to the deformity, or the tip of the screw as a surrogate, but to the deformity. And so when we decrease the kyphosis, we increase neutrality, increase balance, we decrease the forces that would beget that deformity. Basically, what about the properties of the instrumentation itself? So there's this concept of stress and strain. I think that it's probably, who is familiar with the stress-strain curve? There you go, that's all of the orthopedic surgeons in the room. So I'll be very brief with this because the purpose of this talk is to be clinical. But basically, stress is known as force per unit area. In the metric system, it's measured in pascals. In humans, it's typically millipascals. This stress can come in different vectors. It can be compression against the vertebral body. It can be distractive stresses, tensile distractive stresses, or it can be shear at an angle. Now, strain is the response of the object, whatever it is, whether it's bone or an implant, to that stress force. And it's measured in a ratio. It doesn't, because it's a ratio, doesn't have a unit to it. And basically, it reflects the force-resisting ability of the material to that stress that I talked about. And this is the curve that you've got to be familiar with. So this is the classic stress-strain curve. It applies for bone. It applies for solids. It applies for liquids and so on. But most importantly, it applies for implants here. And the application of the stress and the resultant deformation is measured by this curve here. And between B and C is where the important metric lies. And it's known as the elastic zone. And that is that you can apply a certain stress to an implant. It will deform, but by Hooke's law, there's a proportionality, and it can come back to its original shape. Past point C, and that's known as the elastic zone. That slope is known as the elastic modulus, the Young's modulus, and we'll talk about that because it's a quantitative number that is applicable to a particular implant. Past C, which is the yielding point, in other words, where something no longer maintains its shape. So, for example, when you take a rod and you bend that rod by applying force to it, when it stays the same, when it's permanently deformed, that's known as the yielding point of it. And D is absolute failure. It's failure, it's fracture. The implant no longer has the tensile strength to resist the force. So as it relates to the spine, if you were to map out the different stress-strain curves for different populations, you'd see something like this. You'd see that the 21-year-old healthy male is able to withstand a significantly increased amount of stress with respect to their axial spinal skeleton before failure occurs compared to the 80-year-old osteoporotic female. So I think that there's utility in understanding this curve, and that makes sense. So what that means then is that we have to understand what kind of implant can accommodate the physiological conditions of the patient that we're dealing with, right? This modulus, remember we talked about the elastic modulus of the instrumentation. The section modulus is a reflection of the strength of the implant, this elastic zone gradient, and it's exponentially related to the diameter of that inner diameter of the pedicle screw that you put in to the power of 4. We'll talk about kind of the different aspects of the screw itself and the pull-out strength and the ultimate strength. But I wanted to kind of make you understand that we can literally be able to measure the strength of an implant that we put in, for example, a screw, by this metric. So remember, I keep coming back to this elastic modulus. So they're different for different material. So that for cortical bone lies in the range of 7 to 30, depending on your physiological status. Cancellous bone is much less than that. So look where stainless steel or cobalt chrome lies. That elastic modulus significantly higher, 190 gigapascals, 210 gigapascals compared to bone. And titanium itself is significantly higher too. So a PEEK, for example, has an elastic modulus that is much closer to bone than any of these other implants. So it's far more likely to accommodate the resistive forces of bone than having an implant that has far greater strength, far greater stiffness. And so in the war between bone and the implant, you can guess what's going to lose, and it'll be bone. There's other characteristics of the implant, and this kind of sounds like the mental Olympics here. So the implant can be measured in terms of its ductility, the ability of it to undergo a large deformation before it fails, it's brittle, what elastic properties does it display, how strong is it? We've talked about its tensile strength. What about cycle failure, load failure, repetitive stresses before it fails? Notch sensitivity, we'll talk about this, but it's the extent to which you're going to increase the ability of the material to fracture by increasing bending moment within the rod by micro cracks or scratches. And it relates to a rod. When we bend a rod, we create a notch. And that deformation with the impact of where the rod bend is known as notching. And so we'll cover that when it comes to tips for success, but it's a major issue. Ultimate tensile strength, the maximum amount of strength before it can withstand, before it fractures imminent. How tough is it? How much energy can it absorb? How rough is it? What does its microstructure look like? And that really applies to the inner body graft. And Hooke's law, as we talked about, the relationship between the stress and the strain in that elastic zone. So what about bone? So bone is interesting because it has fibers within its cancellous structure that are aligned in a particular way, typically in this vertical orientation, craniocaudal. So the elastic modulus actually depends on the direction of how you load it. It's weakest in shear, then in tension, and it's strongest in compression because of the vertical orientation of those trabeculae in the cancellous part. And so that's a consideration too when it comes to firstly fractures and how we would expect the bone to withstand a compression fracture versus a shear injury. But also the modulus and the stiffness of the rod of the construct that we're going to place. So we've talked about the basic biomechanics of it. What are the ideal properties of these implants? Well, obviously they need to be chemically inert. And as you know, even titanium alloys are not necessarily chemically completely inert. They leach, but for the most part, they are very relatively inert compared to other implants. Obviously can't be toxic. That leach can't be toxic. It has to have strength like we talked about and be stiff. It's got to resist this constant cyclical fatigue. It has to have a low elastic modulus relatively compared to bone. So in an osteoporotic patient, are you going to utilize titanium or stainless steel? Titanium, right? Because it has a lower elastic modulus, so it behaves much more like bone. It has to be corrosion proof. And that actually is important with respect to using different kinds of metals, because you can generate a transfer of ions or an electrical force when, for example, steel is being utilized in conjunction with titanium. So another metal of a different charge property, and a charge can be created that can lead to corrosion. It's got to be able to resist constant wear, and obviously it has to be inexpensive. So what are the commonly used implants that we use in the spine? Well, obviously metal is what we use most commonly. And the three kinds of metals that we've used typically, traditionally, have been historically stainless steel, which was the first kind of implant with a Harrington rod that was utilized. Titanium alloys and cobalt chrome alloys are really what we use now. But there's also non-metals too, such as ceramics and these bioactive glasses. And I think that they're kind of proprietary inventions that come out from time to time with the benefit of better osseointegration into bone. And also other things such as cement that we place in often through our pedicle screws or through needles into the bone itself. So let's talk about stainless steel very briefly. So obviously steel is a combination of different ferrous and non-ferrous elements, basically. So the commonly most used one is this 316L, which is 3% molybdenum and 16% nickel. So what are its advantages? It's extremely strong. It's got a high elastic modulus. It's particularly resistant to stiffness. It's relatively ductile, so it takes a long time or it takes a lot of force before it ultimately fails. So it can resist a lot of deformation before failure. And it's biocompatible, actually. So it tends not to corrode that easily, and hence it was able to be used in patients for many decades. What are the disadvantages? Well, this is kind of, it's cheap as well. The disadvantages, obviously, is that it creates a huge amount of artifact in our imaging. And so it'll really impact our ability to be able to look at the pathology at hand. So what about titanium? Titanium now, pure titanium can be utilized, but typically the titanium screw or rod that you place is an alloy. It's made up of aluminum and vanadium, amongst other things. Again, it's very resistant to corrosion. It's fantastically biocompatible. It's ductile. It's got a low Young's modulus compared to steel. It's MRI scan compatible for the most part. Still not perfect. But the disadvantages are that it has this poor ductility, so there is notch sensitivity. So where you bend the rod, the titanium rod, a notching is created, and that creates a point of weakness in its constituent kind of longitudinal member and subject to fracture in the future. There's leaching, like I talked about. And it is actually still relatively expensive compared to something like stainless steel. Cobalt chrome has the highest stiffness, very strong, excellent resistant to corrosion, but its stiffness is also its disadvantage because in the incorrectly used patient, the osteoporotic patient, where relative decrease in that elastic modulus is needed to meet the needs of that patient with weaker bone, then often you'll see fractures and so on. But you'll see less fractures of the rod. So in a young person with a deformity, an adolescent or a younger deformity adult patient, it may be the implant of choice. It's very difficult to bend, or relatively difficult to bend, depending on your guns, and it'll challenge that bone screw interface like we talked about. There's others. There's Nitinol, a metal shape memory retaining object, highly resistant to kinking. It's got nickel in it, so there's allergy issues with it. And then there's this concept of PEEK. We'll talk about it as an inner body implant, but basically it's used as a rod. It's got a low elastic modulus, shares load. It's small cost, but you can't manipulate it and you can't contour it for deformity. So I'm going to get to the point, which is tips for success, and then we'll finish up. We talked about rod bending. Beware. Select pre-bent rods. That's the point, if it's possible. Titanium is particularly notch sensitive. There's other implants. There's the sublaminar wires where you can bring the spine to the rod, and you can do that across multiple different segments, so it shares that load. Its disadvantage is it can cut through bone, and you can have neurological injury. But there's sublaminar tape which overcomes that by increasing the surface area. Biomechanical forces for the inner body, we don't need to get through that. There's just two things I want to show you. One is PEEK. This is very popular. It's great load bearing, manipulated easily, works well with allograft and inductive agents such as your synthetic bone morphogenic protein. It will never integrate into bone. Remember that. It will never integrate into bone. even if you coat it with hydroxyapatite, you're still subject to delamination and decortication. A certain member of my faculty drilled it into my brain. Beware of peak. Titanium, it readily osseointegrates. It can be modified to integrate with the fixation system that you have. It's difficult to remove when it's fused, but it will, particularly when it's porous, readily integrate into bone. And there are other things as well. We talked about hydroxyapatite. You can increase the porosity of these implants to allow further ingrowth of the bone. The point is osseointegration of that interbody implant into the bone, less chance of subsidence. And this is an evolving field, okay? There's increase in roughness, whether it be done at the macro level or even on a nanoscale, such as there are now implants where there is roughness to the 10 to the power of -9. And it's not just its shape, it drives specific cellular responses, such as osteogenesis, upregulating BMP and other signaling proteins. Okay, we're going to end with tips for success. So I talked to you about the screw. So there's a major and a minor diameter. The core can be tapered, such as a conical core, or it can be straight. The pitch is the difference between the threads here. So a cortical screw has a higher pitch, increased amount of threads. They can be cannulated. They can be coated with hydroxyapatite. Pull-out strength. It's related to a few important things. Firstly, of course, is the bone implant interface of the patient. The material shear strength of the implant and the bone. But there's a few man-made differences that you can apply to your patient. The difference between that major and minor diameter of the screw is important, that thread area difference with respect to pull-out, the length of the screw, and most importantly, the pitch and the angulation. So remember that when you're needing strong fixation in a patient with weak bone. And my tips are to you this. So use the largest diameter screw that you can to reach the cortical surface of the pedicle. Don't use a 4.5 or a 5.5 when you can place a 6.5 or a 7.5 or an 8.5 when it's possible. Utilize cortical screws, because by having increased pitch, you're able to resist or decrease the pull-out of these screws. These cortical screws, you're probably familiar with them. Often they're placed in a medial to lateral angulation, but they have greater pitch, and so it increases the pull-out strength. And utilize a screw where that pitch is increased, at least in the pedicle, which is the strongest part of the vertebral body adjacent to the cortex. There is really no additional benefit past 50% of the vertebral body screw insertion. However, and that's important, because you don't want to be tickling the red bear by putting in big screws. And so take that into account. Triangulate your screws. Like they say, that size isn't necessarily everything. It is in terms of diameter, but at least you can angle your implant, okay? Tapping is important because you can create a milieu for better thread to bone surface interface by already under tapping, for example, by a millimeter or so, and allowing that screw a nice channel to be placed. Consider augmenting with cement when you need to. So 3 key considerations and goals. 1, understand the mechanics of the spine we've talked about, including these forces that we mentioned. Match your instrumentation to the conditions of the spine, and we talked about this. And alignment, reducing the possibility of the deformity increasing in time is key to reducing instrumentation failure. Be competent with your spinal pelvic parameters and utilize your instrumentation to achieve those spinal pelvic parameters. And of course, we'll always tell you your outcomes are best if your patient selection, your surgical strategy, your instrumentation selection, and your surgical technique is maximized. Thank you very much.